Evening, everyone. Myself, I'm Dr. Saras. I'm a consultant psychiatrist. I'm working in Noida. I'm based out of Delhi NCR. So it's great to have you guys all to this first webinar that we are conducting on behalf of YesMindy. So it's an organization that we had set up in year 2020. So it's a mental health fraternity exclusive organization. And as you all know, today is PTSD Awareness Day. So 27th of June, since 2010, 27th June was declared as National PTSD Awareness Day, which is very important to acknowledge the challenges that a person undergoes suffering through PTSD. And also, at the same time, we need to raise awareness towards this diagnosis. I mean, as a clinician, I have not very, it's more than expected that we often come across the patients who are suffering through PTSD, and the person themselves, they are not aware of this diagnosis. So as mental health experts, this day as well is important for us to raise our own, to update our own knowledge and update the treatment available, the sources available. And of course, as society, we need to get together to have some level of empathy, respect, and understanding towards the people who are suffering through PTSD. So celebrating this day definitely highlights the available resources. It highlights the help that is there in their vicinity. And being updated as mental health experts is very important, because this diagnosis as a topic has become very pertinent. This is very relevant to especially the current times. So without wasting any more time, we are very glad that Ms. Sampurna agreed to be an expert for this topic. She did her M.phil and has recently submitted a PhD in CIP, and we are very glad that she accepted our invite to be an expert for this topic. She is currently assistant professor in Christ University, Bangalore. She is a trauma-based therapist, and she is also practicing on the platform YesMindy. Okay, I think Sampurna, we can start. So I think we have enough people now. So you can go ahead and share your screen. I will just confirm if we can see your screen.
I will. I mean, while I'm talking about the topic and all, you can put the questions. I am not seeing the questions right now. I can take them at the end of the session, maybe. So since it's a webinar and it's like a topic that is like more of a there are, and it is aimed at for people who have just started practicing as mental health practitioner. So this is not going to be a very interactive session. Definitely you can pose your questions and I'll try to answer them as much, but it's more of something that I will be talking about much. So if there are any questions, you can just note it down and maybe at the end we can have a discussion of that. So as Dr. Saras mentioned, that this entire month is known as the post-traumatic PTSD awareness month, and particularly today is known as PTSD day. So quite relevant today. And I think as we were talking about, there's a lot of dialogue recently about trauma, and like everywhere there are a lot of there are multiple research work going on. If you just open any like LinkedIn, you'll see multiple blogs and articles being written, and I think pandemic has contributed a lot to that. And just before the session, I myself was reading a blog, and it spoke something very interesting, that how maybe the psychology of trauma has come like a full circle. How when we started off as like the practice of clinical psychology, the therapy and all the understanding. So how we started with childhood trauma and neglect and attachment injury and all of that. And then there were many other waves of like behavior therapy and cognitive behavior therapy and everything. And then again now it has come back to understanding trauma and understanding it as from a transdiagnostic perspective, like even depression, even panic disorder, anxiety, everything can be seen from a trauma lens. So that again makes it very relevant to talk about it. As you all know, or many of you know, that ICD-11 has introduced complex PTSD. The first time it's a diagnosis, but the concept of complex PTSD has been existing since 1992. The term was coined back then, and but then now we have the formal diagnosis of complex PTSD. So we'll try to understand what complex PTSD is, but before that, we'll talk briefly, revise a little about trauma and PTSD, so that it's better for us to understand how complex PTSD is beyond PTSD, right? So I have been already introduced by Dr. Saras. So the thing that I'm going to cover in the today's webinar is, we'll talk about what trauma is, how the trauma reaction is, briefly about the history. This is something because it is the awareness month, and there is a long way that we have come, and there's still a longer way to go. So it's important that we talk a little about the history, how PTSD, what are the core symptoms, and how CPTSD is different. So we'll talk about the diagnostic criteria that has been introduced by ICD-11. Beyond the criteria, we'll try to understand the psychopathology. See, there's a might be a overlap of CPTSD with multiple disorders, most relevant being borderline personality disorder, and very briefly about the assessment and how to do the intervention. I won't go into the details of how to do the intervention, no particular intervention module or anything, but a overall approach is what I could be ending the webinar with. So maybe most of you are aware of this concept of what trauma is. So earlier it was something like there were certain events that were understood that these are traumatic events, like maybe some natural disaster, or how trauma came into practice with war combat or the military combat. So from war veterans. So these were certain events, or maybe sexual assault. So these were typical events that were considered to be traumatic events, and people experiencing that would be known as, would be understood as people who have experienced trauma or the victims of trauma, right? But there is a change, there's a shift of that understanding. So it is nothing, the trauma informed lens talks about that we don't need to have a particular incident. Obviously there are very significant traumatic events that are still recognized, but it is more about the subjective experience of the person. So a person who has experienced physical abuse as a child may not experience trauma, while somebody else might experience it as trauma. So it is about our experience than the event. So there's a shift from that event to the experience. One very important concept of trauma is that it is unprecedented. You are never prepared. If you're prepared for something, then that's not traumatic, right? So it is very sudden. It is very distressing, and it's emotionally shocking. So with trauma, there are changes in the cognition, behavior, and everything. But every time we talk about trauma, or if we ourselves try to think about trauma, the first thing that comes to our mind is it's very emotionally disturbing, right? And the main, as I said, that there's a shift from the event to the experience. So the experience is, if a particular event or an experience renders you unable to prevent the traumatic experience or the harm, then that qualifies as the trauma, right? It could be a single event, it could be multiple events, it could be chronic. Like single event could be something like rape, or experiencing a natural disaster. Multiple could be experiencing maybe sexual assault or maltreatment. Chronic could be maybe a person who is a survivor of domestic violence. So it could be any form, it could be in any format. And it is not always necessary that the trauma reactions would have immediate effect. It could have delayed effect. It could have a long lasting effect also. And something very important is, as a lot of people, they don't understand that whatever they're experiencing are actually result of traumatic experience, or even if they recognize or they understand, which is very common in complex PTSD, is that they don't come out and talk about it, because that, like, there's a thing which will come later, we'll discuss much in detail, where they don't feel the need, or they feel that, okay, there's something happened such a long time back, and why am I still affected by it? Or it's me that I'm so weak, I am not resilient enough, that's why I'm not being able to overcome it. And that's why a lot of people, they have a long lasting effect, but we don't see that as trauma, or the person themselves, they don't recognize it as trauma. So to very briefly say, trauma puts, there are research that has shown that how trauma makes you causes a lot of these neurobiological changes, and it affects our there are changes at a brain, in our brain, and that renders a lot of changes in our emotional processing, the emotional reactivity, our cognition, our and resulting behavior, right? So to say how a trauma experience is, or if you talk to a trauma survivor, the kind of state that they experience, or what they describe is kind of a survival mode. So this is they are always in that mode, that this is how I need to function, okay? And you will see in one of the most significant, or very characteristic feature in all trauma survivors, is that the need to have a control over situation, because how of the unprecedented nature of trauma, how it renders one person very helpless. So from there comes the survival mode, that I have to be vigilant, I have to be in certain way, so that I don't experience trauma again. And also I keep it is not always a person does it consciously, it is at a unconscious level, they have a higher autonomic arousal, and they are always surviving in that mode, you know. So so we are all mostly aware of the fight and flight, but then there are other reaction to trauma as well. So what we understand by fight or flight is the how the HPA axis works, right? But here when we say that fight or flight is a trauma reaction, so what we talk about here is that how we are uh, responding. So there are certain behaviors or action or our thought process or belief system which we are using to fight the traumatic experience, or flight from the traumatic experience, right? So some of the example could be for when we talk about the fight, like there are many people who in their early life they have experienced trauma, and then they have become the bully, or they engage in a lot of explosive or behavior, or they have a lot of anger outburst. Flight is being a workaholic, overthinking. You can have you are always in that panic state, you have that restlessness, perfectionist. So all of this could be trauma reaction, and that would qualify under the flight reaction, right? Freeze is something very I mean, it's quite explanatory. So you seem to be stuck, you feel this, there could be dissociation, there's isolation, you don't know, there's a state of emotional numbness that you experience, and you basically shut down, that's like freeze. Fawn is something which is very interesting, where we find a lot of violence survivors experience, they tend to deal with trauma by fawning. So what they tend to do is they start being you will see this a lot of times, violence survivors would say this as verbatim, that I behaved in that way, that instigated that person to respond that way, so I shouldn't have done that. So they start taking things onto themselves, or they start thinking that if I behave in this certain way, or if I comply in this way, then this will not cause the this will prevent the violence, so they don't recognize the violence cycle, rather they take it, internalize that to themselves, and they start silencing their thoughts, their opinion, and they start repressing their self identity. And the last one is flop, where there are in very major traumatic experiences, people faint. Like this is different from dissociation. So this is uh, like physically loss of consciousness. There could be tonic immobility, and they perceive that there is no possibility of escaping, so they just surrender. This is surrendering at a bodily level. Okay, this is one of the highest way of responding to trauma. I mean, people who have very chronic or have experienced very severe trauma, they might respond with as a flop way. The most common ones are fight, flight, and freeze, and the unlikely ones are, or lesser ones, are fawn and flop. Fawn is often used, seen a lot in the violent survivors. Sorry for this noise. Okay, so as I said, that we'll talk very briefly about the history. Even though today we have this awareness day, or the awareness month, it is quite recent that trauma has been recognized as a mental health condition. There has been diagnosis related to trauma that has been understood, and CPTSD has been recognized or introduced in ICD-11 just recently, right? So if we see the term used for trauma reaction, the first time in the literature that we see is the term used was nostalgia. So this was back in 1761, when people, this was again in reference to the soldiers, and what they noticed was that these people start missing their home, they're feeling very deeply sad, and they don't want to be in the battleground, or they're having sleep problems, or their productivity going down. So it was understood as, oh, this is something that they're missing their home, or there's a major change in their atmosphere, their surroundings, and that's why this problem is happening. Later, it was known as de Costa syndrome. So this was a physician who recognized that along with these feeling sad or feeling missing home, there was a lot of physiological symptoms that also were noticed. That is why when that was introduced or that was understood, it was known as Da Costa's syndrome. Maybe you are aware with the term shell shock. So this was the term introduced for World War One, where it was understood, or it was conceptualized this way, that the traumatic reaction, be it the physiological or the psychological impact, that's happening because the brain gets affected because of the impact of the explosion. So there are, like, from the firing or the bombing, that affects the brain, which is causing these symptoms. And sometimes the term war neurosis was also used, specifically because there were some people who were understood that these are people who have never experienced or been part of any explosion, or have not witnessed anything of that sort, but they're still experiencing these symptoms because they have been involved with war. And that's why it was known as war neurosis. So that was the shift from shell shock to war neurosis. During World War II, the term used was battle fatigue or combat stress disorder. In DSM-1, we had gross stress reaction, and the DSM-2 talked about that we can't just say it's the stress reaction. So it was reconceptualized as adjustment reaction to adult life. It was only in DSM-3 that PTSD as a concept was introduced, and it it was a diagnostic it got identified, recognized as a diagnosis. But as I said, that complex PTSD is as a diagnosis is introduced only in ICD-11, and before this, the diagnosis which comes the closest to complex PTSD is the enduring personality changes due to trauma. But the first time the term complex PTSD was used was in 1992 by Judith Herman. She wrote the book Trauma to Recovery, and that is where the term was used. So it is, see, currently, if the kind of complexities, the difficulties, the stressors that we have, as individually or as a community, as a society, or as a nation globally, it is something that is unavoidable. People will be experiencing something very stressful, traumatic sometime in their life, right? But not everybody who experiences trauma will develop PTSD. There could be there are normal reaction to trauma, like how we have when there is grief, right? The grief is a normal reaction. If there is a loss, there is grief. When that goes at a dysfunctional level is when we talk about it as complicated grief. Similarly, if you experience a traumatic event, so to have certain type of reaction is very normal. Only very less percentage of people who experience trauma will be developing PTSD. And also, a lot of people, they usually recover also. There's a kind of automatic recovery, or people learn, they develop resilience to deal with it. uh, Definitely if they're taking treatment, it helps, right? But when we talk about complex PTSD, we see that how it goes beyond that, right? There is no way to determine that whether this person will experience PTSD when the person has experienced a trauma. But definitely there are certain risk factors, like if the person has an existing mental health condition, if there is any family history of it, there is the person is living in a very stressful environment. So these are all risk factors. At the same time, having a very strong support system, or a person having adequate access to the primary or the tertiary health services, these are all protective factors, right? And even though we give a diagnosis of PTSD, you will often see, if you have seen patients with PTSD, that you will often see that their symptoms are, they will report to you symptoms of anxiety. There will be a lot of worry. There's rumination. There's sleep disturbance. There's eating disturbance, and then there will be a lot of depressive episodes. Then lot of self-destructive behaviors, suicidal ideation, lot of psychosomatic complaints. And people, many a times there are physical symptoms which people don't relate or link to the traumatic experience. There is a lack of understanding of the temporal connection of it. So even though we give that one diagnosis of PTSD, it is kind of an umbrella thing, where a lot of other symptoms also, the symptoms of many other disorders also show. But as we know that PTSD has we talk about it as three core symptoms of PTSD. Most importantly is re-experiencing. So the person stays, uh, remains stuck in that traumatic memory. And one of the most common symptom of re-experiencing is flashbacks. So the person gets reminded of, or the person starts reliving the traumatic memory. This could happen in the presence of a cue or in the absence of cue as well. The other way of re-experiencing is nightmares and night terrors. There are many people who have panic attacks during their sleep following a nightmare or night terror. Okay. The second core symptom of PTSD is avoidance. So that is, if a particular incident has a traumatic event has happened in a particular place, so there is an active avoidance to go there. There is isolation. People start to withdraw themselves after that, so that they don't have to talk about their trauma, or they don't get reminded of their trauma. And also there's a lot of emotional numbing. If you not all of these symptoms will be present in every trauma patients, but in a lot of trauma patients, if you talk, they might say that, like, uh, there are a lot of things that I don't recall. This is what I remember, and this happened, and these are the symptoms I'm having now. What transpired in between, I don't know. Or they, if you ask them, they'll be saying things, or they will narrate the entire thing to you in a very flat way, as if the person is not feeling any emotions. Okay, but at the same time, when the person experiences flashback or experiences nightmares, the person might feel a heightened state of emotion. And hypervigilance, as I said in the beginning, that there's a survival mode where we are always, where the sympathetic nervous system is always activated. You always are on the edge, that there might be something and I will need to be on guard, and I need to prevent something. So you are never relaxed. Your parasympathetic nervous system doesn't get a chance to get activated, and as a result of which there is a lot of stress and resulting to many psychosomatic conditions as well, right? So these are the core PTSD symptoms. The reason why I spoke about this is because this forms the still forms the major cluster of CPTSD as well. Okay, so when we talk about CPTSD, if the diagnostic criteria, if we see, that still includes these three symptoms. So these three symptoms of PTSD has to be present for a diagnosis of CPTSD along with other criteria, right? So when in CPTSD, the flashback we'll talk about is something much more intense and more severe. Or if we talk about the autonomic arousal or the emotional numbing, so these are more severe in CPTSD. However, the symptoms are there in PTSD and in CPTSD. So when the concept of complex PTSD was, as I said, coined by Judith Herman. When she spoke about it, she talked about this: why a person experiences CPTSD. That is because the person remains that is what she termed as dialectics of trauma. That is, the person remains, as I said, that a person remains stuck in the traumatic experience. That is because there are two contradictory responses. One, the person has this intrusion of through the form of hypervigilance. There is flashback, there's night terror, nightmare. So these intrusion is always there, and at the same time there is numbing, there's dissociation, there is avoidance. So a person is constantly there is a imbalance between the two. So sometimes the person is suppressing everything, and on the other end the person is unable to control it because of this intrusion, right? So there's an oscillation between intense overwhelming feeling, and then there are states when the person is not feeling anything at all, right? So this keeps the person's body and mind trapped in the trauma. So the event may be over, but the person remains in that experience, and that is what keeps the person in that survival mode. Okay, so when CPTSD was conceptualized, it was conceptualized as beyond avoidance, re-experiencing, and hypervigilance. It is a disorder of self-organization or impairment of self-organization. So I'll come to what it means by disorders of self-organization. So when we talk about the diagnostic criteria, as I said, that all the diagnostic requirements for PTSD has to be met. And in addition to that, there is a problem in affect regulation. So there is major emotional regulation that is uh, present in complex PTSD. There is a very uh, strong abject feelings of self doubt, shame, guilt, worthlessness, and the feeling of like I am somebody who is worthless, diminished, defeated, and as a result of which the entire perception or the belief about the self, the world, and the others is also affected, and that results in also sustaining any uh, relationship. So they have difficulty forming new relationship, and they also have difficulty maintaining the existing relationship. So they you won't see any active efforts in them. It's very subtle. You won't see any active efforts in them, like they won't be fighting or that sort, but they are always, it seems like they're always on guard. They have that fear of feeling close to others. Okay, so even though it's said that complex PTSD can happen at any time and can occur across the lifespan, but most commonly we do see that during the childhood or the early developmental period. So people who have had major abuse or maltreatment are always at a higher risk of developing CPTSD at their adult life. So people who have experienced maltreatment or abuse, and this talks about that it's not necessary that you have to have sexual assault or physical assault. Even emotional abuse is or just maltreatment, or a person the absence of a nurturing figure, that can also be very traumatizing for a growing individual, and that results in later life in difficulty in affect regulation, in developing a lot of resistance in forming relationship or in maintaining relationship, and a lot of negative self-worth, right? um, there is, as I said, there would be a lot of other symptoms present, as in PTSD also we see anxiety, depression, suicidal ideation. In complex PTSD also we see that, but it is of a higher intensity. Okay. And it's as it's very clear that it's obviously more severe and persistent. So in PTSD, it is usually the time duration within 2 years after the event. If the person uh, more or less, I wouldn't say that the person won't have any reliving experience if there is a very strong traumatic cue, but the functioning starts getting better for a person who experiencing PTSD. But for CPTSD, what happens is, even after a long time, even after a long duration, uh, the person starts continues to have difficulty in functioning, be it at a social level, at an occupational level, or even personal level. And because it has such a chronic and a pervasive graph, it becomes it becomes a way of life of a person, and the person doesn't realize that, like, I am this way. So there could be people who have very strong sense of guilt. You will see that they do, I mean, we all, guilt is something that we all have, these are common emotions, right? But somebody who takes up a lot on themselves, okay, that it's probably on me, that's why this has happened, or the need to be a perfectionist, or questioning, or having a lot of self doubt, that becomes a part of the personality. So as I said, that the closest that comes to CPTSD was the diagnosis, the enduring personality changes due to a traumatic event. So it becomes so pervasive that for the longest time the person realizes or thinks uh, that this is me, this is how I am, this is my personality, this is how I function. And that is why it is so important that see, one thing is to have a diagnosis, and this will help us uh, uh, understand what the people are experiencing and help them with objectively, right? But at the same time, it is important for people to be aware that this may not be your personality, and this could be a result of your complex PTSD, and the diminished quality of life that you are having may not be the real, I mean, the way of life. You can have a better quality of life, so that's also an option. So that wouldn't be possible unless we do the awareness about complex PTSD or PTSD. So so as I said, that it is also understood, it's mostly understood as a disorder of self-organization. So these are the three, as PTSD has those three core features, that is re-experiencing, hypervigilance, and avoidance. In addition to those three, there are these other three uh, uh, typical features of CPTSD, which is negative self-concept. They have extreme sense of shame and guilt, and they always feel that there is something wrong in them. They tend to internalize everything. They tend to take everything on themselves, and they have a very low self-worth. Okay. The other one is emotional dysregulation. So they could be dissociative states. They could be there's a disturbance in their emotional experience as well as emotional expression. Okay. So the emotional numbing could be in the form of experience and expression, and there could be resulting in a lot of self-destructive behavior as well. And the interpersonal difficulty, as I said, so they would have difficulty in sustaining the relationship, and also they have difficulty in forming or maintaining the new relationships as well. So this three qualifies as the disorder of self organization, and along with the PTSD symptoms at a much severe level is what is the clinical picture of CPTSD. But if we try to understand each of this, what are these severe forms of symptoms that we see in CPTSD, right? So something that is very commonly talked about in CPTSD is something called emotional flashbacks. So we know what flashbacks are, right? But in emotional flashbacks, what happens is, in PTSD, the flashbacks are usually for a very brief period. And what happens in that is, the person, some cue, there's a trigger, and that makes the person relieve the traumatic experience for a brief period, and then the person is grounded back to the reality. But in emotional flashback, the reason why it's called emotional flashback is, a lot of people with chronic or complex trauma, they experience this type of flashbacks where the flashback puts them in a very heightened emotional state, where they start thinking that their body and their mind starts feeling that the trauma is happening with them yet again. Okay, they are experiencing the trauma all over again, and that triggers their fight or flight response, or any other form of trauma reaction that is prevalent or dominant in that particular person. So it puts the person in a heightened state of emotional reactivity, and that is also for a longer duration. Okay, so that's what emotional flashbacks is about. As I said, it has a very fragile self-image. Uh, they they are full of shame, guilt, and a lot of self-doubt, and a small cue may start making them question everything about themselves. Like, they might achieve something, and they're feeling that, oh, this is something that I have done. And somebody comes and says, this I'm talking about somebody who is maybe a complex trauma survivor. So somebody can come and say that, you know you should be happy that you have this supporting family, or the supporting partner, because of which you have achieved whatever you have achieved today. And the person starts negating everything the person has achieved. Like, there's no balance in acknowledging the other supports, but also my efforts. That balance is not there. So that self, they have a very uh, toxic level of shame and guilt. Okay, so even if you don't the other person doesn't hold you responsible for something, or don't blame you, you will internalize it, and you will take it as a guilt, that, oh, this happened because I didn't stop it, or I behaved in that way which called for it. So that is the toxic shame and guilt, as a result of which they have huge amount of self abandonment. They think that they are not worthy of anything, and whatever they're getting is more than enough. This is what they deserve, and there's nothing. They don't prioritize themselves, is put simply. There are developmental errors. So as I said that, complex PTSD is most commonly seen in people who have a history of experiencing trauma from a very early age. So that results in developmental arrest. So while the person, so we know that how from temperament, then there's the development of the personality, and the environment plays a huge role in that development of the personality. And if the environment is very traumatic, then that will obviously impact in the development of the personality, the development. So we have our basic understanding, I believe, about how moral development takes place, or how our cognitive development takes place, how we develop our beliefs about ourselves, about the world, about the future, about others, our significant others. So all of this development starts getting affected because of the complex trauma experienced right from the early developmental period. There is a radical mood vacillation that takes place. You wouldn't see a lot of uh, emotional outburst in people, but they experience a lot of mood vacillation. The reason why they experience very high and low mood oscillations, but that they don't express that enough, because again of their shame and guilt, or their self image, that I am anyways at a disadvantaged position. So I don't have any right to be, like expressing my anger or uh, yelling at anybody. So they start holding that onto themselves, but they experience very radical mood vacillations. Dissociation is very common in both PTSD and complex PTSD. Relationship difficulties, as we discussed already, they tend to become very oversensitive. Okay, so they might I mean, again, they might find a basic criticism or a feedback or any kind of like a person uh, acknowledging them, or a small event or cue, and they might get triggered by all of that. But yet again, they won't express, because of that fragile self-image. There's a lot of feelings of loneliness and abandonment. And very interestingly, something called there is suicidal ideation, but one very distinctive feature of complex PTSD is passive suicidality. Okay, so just kind of summarizing about the psychopathology. So as I said, that emotional flashbacks is the most uh, common. So what we talked about is the affect regulation, disturbance in the affect regulation, or the relationship problems, or the self image. These are the symptoms that we see. But the experience, when we try to understand why what is the person experiencing which is resulting in these symptoms, it is the emotional flashback that the person is experiencing. So these are prolonged regression to the overwhelming feeling states, so that when the traumatic event took place, the person goes back to that emotional state. It could be fear, it could be shame, alienation, rage, anything. And it also triggers our fight or flight instinct. It can range from very subtle to horrific. So you might see a person getting triggered and having very subtle, you wouldn't even realize that the person is having flashbacks and the person is in a heightened emotional state. But it can also be to an extent where it starts affecting the person's functioning, the person stops going to work, or that one entire day the person is not being able to function. This is something which people, therapists who are working with complex PTSD survivors, call it as regression. Okay, so this regression is not the defense mechanism regression. This is regressing to the emotional state when the traumatic experience happened. Or a lot of times what happens is the traumatic event takes place, and then we have our own interpretation. For any event, we have our own appraisal and our interpretation. So when we have formed the schema of that particular traumatic event, the kind of emotional state that we have experienced is what the person goes back to. And the person remains in that state for a prolonged may remain in that state for a prolonged period of time. And that is what is called as regression. Okay, so it you, again, you may not, from a, as an outsider, you may not realize that the person is in that state. Okay, you might find the person being not being able to the person is behaving a little different, is a little more anxious, is very startled in small things, the person is having sleep disturbances and all of that. That is what you will be able to see. What is internally going on is maybe the person has regressed back because of an emotional flashback. Okay, there's this concept of toxic shame, that it is something wrong in me. I am fatally flawed. Okay, which is why this has happened to me, and I am still carrying it. I don't have the uh, power or the agency to come out of it. So, which is why I'm still stuck there. And this also inhibits the people from seeking support. Okay, because they think that it's something wrong in me, right? So it is big, they don't realize that I am responding in this way because of the traumatic experience. Rather, they think that I am responding in this way because I couldn't deal with that, which is the toxic shame. Passive suicidality is, I think you all, if you're not aware of what is the difference between the death wish and suicidality, passive suicidality kind of lies a little between the two. So in suicidality, what we have is, suicidality is uh, when we talk from a trauma lens, we don't see suicidality as the wish to end the life. Suicidality is the inability to continue living. So the person doesn't want to die. The person is not being able to live further. From a trauma lens, we see suicidality that way. And death wish is where the person doesn't want to do something actively to end the life. So there's no suicidal ideation, but the person wishes there's nothing going to get better. So it's better that this just ends. In some way or the other, my life ends and I just die. Passive suicidality is a concept of CPTSD where we talk about that the person wishes to be dead, but at the same time, the person also fantasizes about ways to end the life. So this term fantasizing about ways to end your life was used by Herman, where she said that, they're not making any active efforts. If you check the lethality, what we do in suicidal assessment, you may not find any lethal attempts or no lethal ideation, but it is a constant rumination in the person where the person thinks, if this happened to me, I would have died, and it would have been an end to all of this. Or if you read the book, you will see there are multiple snippets of the patients who have experienced complex trauma and how they report, like when they see a news of maybe a massive flood that has taken place, and the person immediately gets a thought that, I wish I was present there and I would have died. So they are so stuck in that, they feel that they are so helpless that they don't have the agency to even end their life, but they don't want to live any further. So they think that passively, if this happened to me, I would have died. Okay, so in death wish, they think that something happens and I die. But in passive suicidality, what the differentiating point is that they think about these different ways that could have happened to them, that could have killed them, but they are not actively seeking to do those things. So that is what differentiates suicidality between PTSD and CPTSD. And yet again, you will find it very difficult to elicit that from individuals who have experienced complex trauma. Now, as I said in the beginning, and with the diagnostic criteria or the psychopathology, you probably have understood that there is affective dysregulation, there is interpersonal difficulty, there's a problem with the self-image, which is also present in BPD, right, in borderline personality disorder. And there's a lot of, even in the ICD working group, there was a lot of debate related to this, that does BPD, which is an existing diagnosis, kind of explain and attributes to all the symptoms of CPTSD, and is there a need to have a separate diagnosis for this? There's a group of people who said that how there is a difference. So definitely there is an overlap there. The traumatic experience is very common in, it is the source of CPTSD, and it is also very common in BPD, right? We know that how early age neglect, abuse, maltreatment, all of this contributes to borderline personality traits. There is affective dysregulation, there is disturbance in their interpersonal relationship, their IPR is very disturbed. So there is obviously overlap, but there is a very fine line between CPTSD and BPD. So if we talk about the emotional dysregulation, so the problem that CPTSD more often has is the difficulty in self-calming. Okay, so as I said, that because of their poor self-image, you may not see a lot of times them, not necessarily that it's a all or none, that there will never be any outburst, but it is more of an internal process, again, because they think that there's something internally wrong with them. That is why it's on them to if I am feeling this way, it's my fault, so I need to do something about it. So they have that difficulty in regulating their emotions, and it's obviously, if lot of emotional regulation depends on us, but also at the same time on the environment. If my environment is stressful, if the environment has a chronic stressor, then it is not possible for me to take charge of everything and blame myself for having these emotional disturbances. But that is that what happens in CPTSD. And also this sense of chronic emotional numbing. Even borderline patients do have emotional numbing, but it is in CPTSD it is more chronic than BPD. The differentiating factor from of BPD and CPTSD is the emotional lability. So you won't see this amount of lability in CPTSD as you see in BPD. Even if it is there, you will not be able to see it from outside, because again, the outburst or the expression is very numbed. And there is a major emotional discontrol, as in with the expression, so which is lesser in CPTSD. But there could be again a overlap between these two. With the negative self perception, CPTSD has this chronic sense of guilt, shame, and worthlessness, which we talked about, the toxic shame or the poor self image. However, in BPD, the people with borderline personality also have this sense of chronic sense of guilt or this emptiness, but their sense of self is more fragmented. It's more unstable. It is not always that this experience this chronic sense of worthlessness. There is one trigger or something, and that uh, causes it. But in case of CPTSD, it is either whether there is any positive event or negative event, irrespective of that, they experience this chronic sense of shame and guilt. When we talk about relational problems, uh, there is a avoidance and detachment more in CPTSD, while in BPD what we see is there is a what we talk about it, right? There is enmeshment, and at the same time there's a disengagement. So they alter between extreme idealization and then devaluation, right? So that is there in BPT, which may not be there in CPTSD. Having said that, it is very common that people who are with this new diagnosis of CPTSD, many people who are diagnosed with borderline personality disorder may require a revised diagnosis and will qualify as CPTSD. And there are many research and there are many articles available recently on this, where it talk, because we all being in the mental health profession, you probably will be aware of how there is a lot of stigma associated with personality disorder, particularly with borderline personality disorder, right? Now, if that gets explained as a personality resulting, or the personality changes or resulting from a complex trauma, that may help them get better, seek better help and reduce the stigma. So many people will require a revision of a diagnosis. Yet again, not all person diagnosed with borderline personality disorder will qualify as a person having CPTSD. It is a very fine line. People with CPTSD may and mostly will have a lot of borderline personality traits, and somebody with borderline personality disorder may have complex trauma or very early life developmental trauma. So there is a overlap, but uh, with that conclusion only, ICD-11 has retained the diagnosis of borderline personality disorder and has introduced the diagnosis of CPTSD. As I said, it's a fine line. It will be difficult to diagnose, but uh, you know, it is important that how we interview, how we assess, and how we do the intervention. So whether when it comes to the intervention part, it becomes immaterial whether it is borderline personality, what is the diagnosis, borderline personality, or it is CPTSD, because what we are trying to deal here with is the distress the person is having, the impairment the person is having, and that is irrespective of the diagnosis. But if we are trying to assess and give a diagnosis, there could be a difficulty, and there could be an overlap also. So that is something that is still being worked on, and that is the main reason why DSM-5 has not introduced CPTSD. So well, DSM after DSM-4, there was a working group that was in favor of introducing CPTSD in DSM-5, but this is the reason why it was not introduced in DSM-5, but has made a place in ICD-11. So very, as I said, very briefly, I'll say how to work with CPTSD. So as I said, it's a very difficult population to work with, and we need. I'm sure that with time we will be more equipped to identify and help people with CPTSD. Even the awareness will grow, so people experiencing complex trauma and experiencing this kind of disorganization, disorder of self disorganization, will also come forward. So, but whatever it is, just keep in mind, if you are dealing with any trauma survivor, irrespective of whether it's complicated grief, it's PTSD, it's CPTSD, it's borderline personality, it's very important that we adopt a trauma informed lens. I'm not getting into the details of what trauma informed lens is. That's a entire topic altogether. So that, but it is something that is important to have, because it's a very completely different perspective to look into trauma. The first step of it is not focusing on the trauma event, but on the trauma experience. For assessment, ICD-11 has published this questionnaire, which is known as the International Trauma Questionnaire. This is supposed to, it's a diagnostic tool which is supposed to be used for diagnosing PTSD and complex PTSD. So I think we can share the resource after the session, where you will see the scoring and the interpretation. So what are the features of PTSD, and what, how the person will qualify for a diagnosis of PTSD, and how the person will qualify for a diagnosis of CPTSD. But a tool cannot be all. It is our clinical judgment and the interview skills that also needs to be in place for the diagnosis. And there are multiple interventions that so mostly research says that whatever interventions are effective in PTSD and borderline personality is also useful in CPTSD, but keep it in mind that it has to be a holistic approach, because it is affecting the person. It is a pervasive, it's a chronic thing where a person starts believing this is how I am and this is what my life is like. So it has become the person's way of life. So if you have to bring a change, the change has to come in the self, in the way they see the external world, the way they see themselves, the way they see the future, the way they interpret the appraisal, everything. So, and also at the same time working with their anxiety, their depressive feelings, the sleep disturbances, their yeah, the impairment that they have, the kind of maybe the perfectionism in their work, or being a workaholic, or having some maladaptive eating habits. So it has to be at a very holistic way. You can't be just targeting on the trauma and the trauma experience, because the impact of it is very diverse. So, having said that, I think this was about CPTSD. It's very briefly discussed, and it is something that needs a lot of learning. I mean, reading, and also at the same time practicing. These are some of the books that I have referred and I have read to understand CPTSD, and also overall to work with uh, trauma survivors. If you want, I can share the materials also later. So that was the topic. I think we can take.
Yes, Sampurna. Yes. So we have a couple of questions already there. In case anybody wants to ask any question, if you would want to type and send it, we will address it from the chat box. Or in case anybody wants to have a like brief, they want to talk something about their experience, or something important about the patient, you can raise your hand, so I allow you to talk. So you can, if anybody wishes to talk, so I can allow accordingly. But if in case you have any questions, so you can post it on the chat box. So one question has come up, Sampurna, that says that are there any demographic groups that may be more prone to CPTSD, and if so, why? Yeah, I think you're on mute.
Yeah, so I think everybody who have experienced or does experience childhood maltreatment or abuse uh, do have are definitely more likely to have CPTSD, or people who are survivors of violence, or people who are living in maybe very geopolitically disturbed areas. Okay, also with the geopolitically disturbed areas, there's a lot of intergenerational trauma also that passes down. That also is something that makes you more vulnerable to CPTSD. Or people where if there has been domestic violence that the person has seen while growing up at their home, that also, that intergenerational trauma is also carried forward. That also makes you more vulnerable to CPTSD. But unfortunately, in so far in India, we don't have any data as to what is the prevalence rate for CPTSD. Actually, the epidemiological finding for PTSD itself is very limited in India. But yeah, so for CPTSD, so far we don't have any data in India.
Right, right. And the other question that has come up is, as explained, CPTSD and BPD overlap. What would be the treatment approaches for these conditions? Would they be same? Which condition would you prioritize in treatment? So I think this is
Yeah, so I
cumulative
think
of two, three questions
yeah,
together.
I said that when you are doing planning an intervention, so see, when we give a diagnosis, that time we may think about the chief complaints and the diagnostic criteria. But when we are planning an intervention, we have therapeutic goals, which is very different from the complaints. So the therapeutic goals is always im- the most important is to improving the functioning of the person, or reducing the distress. So whether whatever be the diagnosis, that takes a uh, backseat. So and so if you're focusing on the experience, the negative self, or the affective dysregulation, depending on which mode of therapy you choose, and that addresses the impairment and the distress, I think should be effective. Uh, you don't need to go for, oh, this is the BPD diagnosis, or this is the CPTSD diagnosis. So what I do is, irrespective of like how we were during our training, we were taught that when you're doing a clinical interview, you, irrespective of the diagnosis, you inquire about the suicidal ideation, right? Because you never know when the person has a suicidal ideation. Similarly, it's very important maybe to inquire about any kind of violence, abuse the person has experienced, and there could be any trauma that the person experiences. So the lot of symptoms could be explained from that. So the transdiagnostic lens talks about that. So during your interview, if you can elicit that information, that will help you plan the intervention. So in that case, the diagnosis wouldn't matter that much.
Okay. One is, how is perfectionist nature under flight? Uh, I think in the 5 Fs that you had mentioned, so there was perfectionist under the category of flight. So somebody's asking to explain that.
Yeah, so what how trauma explains perfectionism as flight is that, suppose you are given a task, and you think that if I don't do it in this particular way, then it's that all or none thinking, that if I need to be at this end, only then the work gets done. So it is not always that it is related to the trauma. So For example, if a person is workaholic also, it is not necessary that it is related to the traumatic event. It is the experience that leaves an impression. So the person feels that I need to do this much extra, uh, otherwise I will not be able to achieve the goal, you know.
Right.
That is uh, the trauma response we're talking about.
Okay. Right. Is the diagnosis of CPTSD lifelong, or what are the factors affecting the prognosis?
uh, it has a very pervasive course, and most of the people, they do, uh, I mean, as I said, like very few people so far gets the diagnosis of CPTSD, or they come up with these complaints because they think that this is the way of life. So I don't think it's a lifelong diagnosis, but it's very early to say that, because as I said, there's very limited epidemiological data. So what is the prognosis? Again, it's very, because it's so pervasive, it has so many developmental changes, it causes so many developmental changes in the early life, that it is most likely to have a poor prognosis. As I said, that they are very oversensitive, and something later also might just put them back into, you know, like slide them back to that state. So it's a very tricky situation right now to comment on, but definitely the prognosis can be improved if you address it. uh, it can definitely be improved.
Right. Oh, I believe that having sort of strong temperamental foundation, not having many personality problems, uh, along with CPTSD will definitely improve the prognosis. But yes, CPTSD along with BPD will definitely be something that will turn out to be with a bad prognosis.
Yeah.
But yes, if there's good support system, underlying personality has better copings, the adaptive behavior is more positive. So I think that would be one of the positive prognostic factor. Right. Uh, right. The other question. Uh, Right. I think we have answered the questions so far. Uh, the one question, Sampurna, that I would like to be answered is that why was there a need for complex PTSD to be brought about? Like, what was the, in nutshell? I'm sure you must have touched that in your presentation, but in nutshell, what was the requirement for complex PTSD?
See, the thing is, a lot of people with these early abuse, maltreatment, and everything, because of their emotional dysregulation, or the kind of the interpersonal difficulties, very loosely get diagnosed as BPD. Or as I said, there's a lot of stigma associated with it, or they're often labeled as like the difficult people, you know. But it is and that kind of reinforces their that negative self image. uh, and if uh, like how, you know, like with every patient, when we are doing the psychoeducation, it is a part of it that we assign the sick role to the person. So if we don't uh, acknowledge the complex trauma that the person has been experiencing, and this result the resulting personality that you have is not just you, but also the interaction with the traumatic events, you know.
Mm.
If that is not done, then you can't really develop the agency in the person also, that you can do anything about it. So as I said in the beginning, like we have come like a circle, that where again we are talking a lot about trauma, but uh, there's the job doesn't end there, that okay, so my personality is like this, or I am behaving this way because I have experienced the trauma. It's right that you have experienced the trauma, but that doesn't define you. So you have the agency to overcome that. It's a difficult process, it's a very lengthy process, but there are ways. You may not achieve the 100%, but every small step counts, right? So you don't need to be stuck in that trauma state. You can come out of it. So to give that agency, I think it's important that we have a objective nomenclature, so that people, like, there's not much of a stigma, or that constant internalization of thing that this is how I am, or this is why people avoid me, or this is I am a difficult person. So kind of explains that.
Right. No, I'm as a practitioner, I am very comfortable. It highlights the role of trauma in the complex behavioral and emotional issues that we see in our patients. So, as you said, we take up in the history. We definitely record it in the history as a factor responsible for the problem that he or she has today. But then, in due course time during the treatment, the trauma takes the backseat, and we forget to link that with the current problem and the treatment. So complex PTSD, I feel, is required to highlight the role of trauma in the emotional turmoil of a person's life.
Exactly. Yeah,
Right.
and that, and also, as you said, like, that trauma takes a backseat. So that's why having that, whenever you're dealing with a trauma survivor, you're working with a trauma survivor, it's very important you have the trauma informed lens, where uh, it is not the traumatic event, the traumatic experience, but not being stuck there, but to have that agency that you can have few, you can at least take few steps to come out of it. uh, it is up to you whether you want to or not, or in which way you want, or whether when you are ready for it. But to have that approach, that, like, this anxious self of yours, which is interfering with so many things of yours, you can do something about it.
Right.
So
Right.
giving that thought to that person.
Right. Right. Okay. Thanks. There is one more question that has come up by one of our senior clinical psychologists. Can you stress upon the role of family and partner support when dealing with clients with PTSD?
Yeah, I think that, social support, family support is something which is important for any mental health condition, uh, especially when we are talking about the emotional reactivity, or the sense of self. So the family, the family, the partner, or the significant one, others can actually be a major buffer for a person to not experience or be stuck in that traumatic experience. So again, when we work with trauma survivors, involving family, or involving their partners, or if there are nobody that they have in the family who is supportive, connecting them to many support groups, that will also help them, because you really can't, uh, it's very difficult to work with that amount of negative self image and that amount of affective dysregulation all by yourself. Your therapist can be there to help you in the process, navigate you through the process, but you need people who are close to you to constantly validate you or give that support to you. So the best practice would be to involve the family members, or whoever the person is comfortable with. That need not be necessary that the person has to know everything about the trauma, but
Hmm.
the role that the family members can play can be incorporated.
So, in the meanwhile, I had conducted few polls while the presentation was ongoing. So, I have just published the results. So, one was which is the best movie on PTSD have you seen? So, result, it had choices of so it's there. I think everybody should be able to see the poll. Well, Sniper, Machinist, Cherry, Brothers, Mockingjay. So I think Machinist has won. People have mostly voted. The second best is Sniper. So these are the list of few movies that are available for people to watch and learn about PTSD. Other question was, do you think there can be an overlap between PTSD and BPD. So yes, so 94% people have answered yes. Which scenario is, as per your experience, more common? This has turned out to be 50-50 exactly. PTSD with BPD or BPD with PTSD. So, so this has turned out to be 50-50. So this is a topic of discussion that can be taken up sometime. Uh, I narrated a case history. A 2-year-old child was a sole witness to his father falling into waterfall and later sees his body after a few days. Can this child have PTSD? So yes, people have agreed that 94% people have agreed that a 2-year-old child can also suffer through PTSD, and it's not about when the symptom is visible. It is not about that anymore. It takes
And it can
time to
also
surface.
be, yeah, and it can also be possible that this child may not recall the event, what
Hmm,
happened. The
hmm,
child will always, maybe the child will have a heightened anxiety, and
hmm,
functions in a heightened anxiety state, or
hmm,
often feels panic, and all of those symptoms may be present, and the person may not ever relate that this is why. Or maybe, like later the child hears from the family members and then kind of relates. So many trauma survivors, they particularly who have experienced trauma at a very early age, they don't recall the traumatic event, uh, or they vaguely remember, but they remember the emotional state that they were in, or the autonomic state that they were in, and they continue to be in that kind of a state. That is what the stuck feeling is, when so common in trauma.
right, right. So yeah, just the last question I asked to the audience. So one was, do you know about YesMindy? So people, it's again 50-50. So so just to end this webinar, thank you so much, Sampurna, for giving us the time, your knowledge, your experience that you have shared with us. It will definitely, as to me as well, there were a couple of points here and there which I could pick up, and I'll be able to use with my practice. So I'm sure there were many students and emerging mental health experts here. So thank you so much for giving us this knowledge and helping us raise this awareness towards this CPTSD. And thank you so much to the audience to join. And this was one of like our first webinar. We will be conducting a few more to come. Like we are an organization, YesMindy. It's a tech-enabled platform. We started in the year 2020, and we are looking at establishing ourselves as a very strong mental health brand, which forms a community of mental health professionals. It will be uh, uh, more fraternity oriented. So we are bringing in people who are practicing professionals. We are bringing in everybody together, and we provide tech-enabled solution. So we are a mental health tech-enabled solution platform. We are empowering clinical psychologists and psychiatrists to be able to deliver the treatment efficiently with their patients with a lot of our features. So if you have any interest to know about more about the product, more about YesMindy, you can drop in the mail. You will receive a mail from YesMindy, and we will have future webinars, and we will keep all of us as a community will be engaged with each other. Okay, all right. Then thank you so much. We hope to see you soon. Yeah, thanks. Bye.
Thank you, everyone.